All right, today we are diving deep, really deep, into neuroborreliosis. This is the complex and, frankly, often severe neurological fallout from Lyme disease. So, here's our game plan. We're going to start with how the disease actually looks in a patient, then get into the nitty-gritty of diagnosis, treatment, and prevention. We'll also cover the long-term impact before we wrap up with a quick review to make sure the key points really stick. Okay, first up, the clinical spectrum. You have to understand, neuroborreliosis is a true master of disguise, so getting a handle on its many different faces is absolutely essential.
You know, what's fascinating is that in Europe, the specific species of Borrelia can often give you a clue about what you're going to see clinically. If it's Borrelia garnier, you're more likely thinking neurological problems. If it's Borrelia fcelii, you tend to see more skin-related issues. But I have to stress, there's a lot of overlap here.
So in Europe, the textbook case, the classic presentation we look for, is something called Bonwarth syndrome. It's a triad. One, incredibly painful nerve root inflammation, we call that radiculitis. 2, problems with cranial nerves. And 3, lymphocytic meningitis. That intense, radiating nerve pain is often the very first and most dramatic clue. Now, if the disease isn't caught early and becomes chronic, well, this is where things get really serious. We're talking about a devastating, full-on assault on the nervous system. This isn't just a list of symptoms. Each one of these represents the potential for severe, lasting damage, from inflammation of the brain and spinal cord all the way to a stroke. It really highlights how high the stakes are if a diagnosis is missed. Okay, so with symptoms this severe, the big question is, how do we actually prove what's causing it? And that brings us to diagnosis, which, let me tell you, it's a real challenge, because this pathogen is incredibly sneaky. Just to put it in perspective, think about this. If you take cerebrospinal fluid from a patient and try to grow the Borrelia bacteria in a lab, your chance of success is only about 10 to 15%. It's just notoriously difficult to culture, which makes it pretty much useless for a routine diagnosis. All right, so if culture is out, what about PCR? Well, its usefulness is very, very specific. As you can see here, for diagnosing neuroborreliosis from CSF, the sensitivity is just too low to be reliable. But for something like Lyme arthritis, where you're testing fluid from the joint, or a skin biopsy from a specific rash, now you're talking. The sensitivity shoots way up, making it a valuable tool in those contexts. And all of this brings us to the absolute gold standard. The single most important diagnostic test is proving that the body is producing antibodies inside the central nervous system. That's what intrathecal production means. It's the smoking gun. With sensitivity approaching 100%, this is how you definitively diagnose neuroborreliosis.
So once you have that solid diagnosis, what's next? Let's talk about treatment. And the key here is being evidence-based and really specific to the patient's condition. The big principle here is that there's no one-size-fits-all approach. You really have to tailor the treatment. For something severe, like late neuroborreliosis, you're looking at a pretty intensive course, often 4 weeks of IV ceftriaxone. But for other things, like late Lyme arthritis, you can get excellent results with oral doxycycline. It's all about matching the right drug, dose, and duration to the specific clinical picture. Now, there are some really important nuances to keep in mind. First, for European cases, good news. Studies show oral doxycycline can be just as good as IV treatment, which is a big deal for patients. On the flip side, amoxicillin, it's really not the best choice for late-stage disease. And this is a huge one. For patients with persistent, subjective symptoms after treatment, giving them more and more antibiotics just doesn't work. It's been shown to be ineffective. And for kids under 9, we're typically looking at ceftriaxone or penicillin G for early neuroborreliosis.
All right, moving beyond treating the individual, let's zoom out a bit to public health. What can we do about prevention and reporting? So how do we stop this before it even starts? Well, step 1 is obvious, right? Avoid getting bitten by ticks in the first place. Beyond that, we have options like post-exposure prophylaxis after a high-risk bite. And here's a really interesting development. Using sustained-release doxycycline might not only prevent Lyme, but could also protect against co-infections from other nasty things the tick might be carrying, like anaplasma. Okay, now we're getting into what is, frankly, one of the toughest parts of this whole topic.
the long-term complications and after-effects that can stick around even after standard treatment.
We often hear this referred to as post-Lyme disease syndrome, or PLDS. And while the good news is that most patients, the vast majority, do recover completely, a significant chunk, maybe up to 20%, don't. They're left with these really debilitating symptoms. And why that happens? Well, that's the million-dollar question and the subject of some fierce debate. And I really want to stress, we are not talking about vague feelings of being unwell here. These are documented, severe, objective conditions. We're seeing chronic arthritis, chronic neuroborreliosis, even heart problems like a weakened heart muscle or AV block. In the most severe cases, you can get cerebral vasculitis leading to a stroke or brain hemorrhage. This just underscores the devastating potential of this disease. All right, before we hit our final review, let's lighten the mood for just a second. Ready? Why did the Borrelia bacteria break up with the spirochete? Because they had too many unresolved issues, especially with the central nervous system.
Okay, let's get serious again. To wrap things up, let's do a quick knowledge check and review the absolute must-know diagnostic principles.
So let's drill this down. Key takeaway number 1, diagnosing neuroborreliosis means using indirect methods. 2, culture is basically useless because of low sensitivity. 3, intrathecal antibody testing in the CSF, that's your gold standard. 4, PCR is a specialty tool for specific situations, not a go-to for CSF. And finally, super important, if a patient's antibody tests stay positive after treatment, that's normal. It's an immune memory, not a treatment failure. All right, test question number 1. What is the primary limitation of using Borrelia culture for diagnosing neuroborreliosis? Is it A, high cost, B, low sensitivity, C, contamination risk, or D, long turnaround time? And question 2, which diagnostic method is considered the crucial high-sensitivity test for confirming neuroborreliosis? Is it A, PCR on blood, B, culture of synovial fluid, C, intrathecal antibody production in CSF, or D, routine CSF pleiocytosis? Okay, let's see how you did. For question 1, the answer is B, low sensitivity. The bacteria are just notoriously hard to grow. For number 2, the gold standard is, of course, C, intrathecal antibody production in the CSF, and remember that other key point. If antibodies persist post-treatment, that's C, a normal finding. It does not mean treatment failed. And that brings us to our final, lingering question. It's the big one that hangs over the field. Post-Lyme disease syndrome. What is it really? Is it a persistent, hidden infection that our antibiotics just can't reach? Or is it the ghost of the infection, a post-infectious autoimmune or inflammatory cascade? The debate is very much alive, and finding the answer, well, that's one of the most critical frontiers in all of Lyme disease research. Thanks for joining this explainer.